In addition to the identification and characterization of a pleural effusion, the bedside sonographer should be able to perform a semi-quantitative estimation of the amount of fluid present. In most circumstances, it is sufficient to qualitatively judge a pleural effusion as small, moderate, or large. With experience, assessment of the amount of pleural fluid will become relatively easy and will in general not require any measurements to be taken. A rough estimate of the importance of the size of a pleural effusion can be obtained when scanning the supine patient in the lateral zone and assessing where the fluid is visualized in relationship to the posterior, mid, and anterior axillary lines. This has been described in a previous section of this course. In brief, if the probe is placed at the upper boundary of the lateral zone, that is, in the anterior axillary line, fluid will be visualized in the ultrasound plane only if the effusion is massive. A less important effusion would be missed with such an anterior probe or ventral probe position on the chest. If the probe is placed in the middle of the lateral zone, that is, in the mid-axillary line, effusions that are large and moderate in size will be visualized. However, effusion of smaller size and more posteriorly located will not be visualized with such a probe position. When the transducer is placed in the posterior axillary line, literally touching the bed, effusions that are large, medium, and small will be visualized. Those effusions that are very small will possibly be missed with the probe in the posterior axillary line and will only be visualized if the probe is positioned below it in the subposterior area. Please refer to the section on probe handling and position for more details in the latter point. When examining patients in the supine position, the volume of fluid seen on ultrasound correlates better with the actual fluid volume than the amount of fluid estimated from a lateral decubitus chest radiograph.